start with you first. So Himani would be speaking on unveiling the unforeseen, a rare case of delayed EBMD post-femto LASIK. You ready? Yeah.
Good morning, everyone, esteemed panelists and my dear colleagues. I'm here to present a rare case report of unveiling the unforeseen. So, a 29-year-old female patient from Eastern India had undergone uneventful femtosecond assisted LASIK for myopic astigmatism for a refractive error of minus 2.5 spherical and minus 1.5 cylindrical at 90 degrees in the right eye, and minus 2.25 spherical and minus 1 cylindrical at 90 degrees in the left eye with BCVA 6/6 in both eyes. So she presented after 1 month with blurring, irritation and mild redness photophobia in the right eye. There was no recurrent corneal erosions or fingernail trauma in the past. Her family history was non-significant, and her drug history, she was on hormonal therapy for polycystic ovary disease 1 year back, and she had stopped the treatment since last 1 year. Her socioeconomic history was not significant. Her general examination and systemic examination were not significant. On ocular examination on the day of presentation, she had a visual acuity of 6/12 in the right eye with a diffuse haze at 7 o'clock position at the margin of the LASIK flap with overlying epithelial cysts suggestive of stage 2 diffuse lamellar keratitis. So here in the picture what you can see is the black arrow shows the epithelial cysts and the white arrows shows the diffuse lamellar keratitis at the flap margin. So this was the antersegment OCT done on the day of presentation. So the white arrow shows the epithelial cyst and the blue arrow shows the diffuse lamellar keratitis at the flap margin. So we started her on topical hourly steroids, prednisolone acetate 1%, but we had a surprise awaiting. So on the day 2, she had a clinical picture like this with worsening of symptoms and a epithelial defect with in the pupillary axis with diffuse lamellar keratitis. So what we did was we stopped the topical steroids immediately, and we did patching with bandage contact lens for 48 hours with antibiotics. She was symptomatically better after 2 days of patching, and even the epithelium started healing. So after the healing of epithelium, we started her on tapering dose of topical steroids, and the diffuse lamellar keratitis healed completely with minor residual refractive error. The enhancement was not done. So this is the final picture of where we can see the epithelial has healed completely. Her final BCVA was 6/6 in the right eye with residual refractive error of plus 0.75 cylindrical at 165 degrees after 1 month. So the patient did not want a re-enhancement. So we present a case of EBMT, epithelial basement membrane dystrophy, diagnosed 1 month after the femtolasic surgery. So similar case was first reported by Garcia and Gonzalez after 4 days of femtolasic, which is the presenting sign of a silent EBMD. So the shearing force of the microkeratome blade results in a epithelial defect after the microkeratome LASIK, whereas in our case and also the previously reported cases, the surgical trauma from the docking procedure with the femto laser might have been very less. So it causes a significant delayed subclinical EBMD. So to conclude, identifying epithelial basement membrane dystrophy preoperatively is very important for refractive surgeons to prevent such kind of complications, and also in cases where it is detected perioperative or postoperative period, these patients must be followed up and treated meticulously to prevent vision loss. So here are a few of the references. I would like to acknowledge my mentor and my colleagues. Thank you.
History of the same disease was there?
No.
Nothing. Did you stain the case and see?
Yes, we stained it. Actually, I did have a picture, but the picture quality was not so good. That's
so
why.
What was there after stain? What could you
yes,
see?
it stained with fluorescein. But initially, when the DLK was there, it stained positive.
Okay, so that is a very important slide that you missed.
What about the other eye? EBMD usually is bilateral. So
yes, but the other eye did not have any symptoms.
Another thing, the case presented the very next day.
No, after 1 month.
Presented after 1 month.
Yes.
So how do you conclude that it was because of the femtolasic?
Because,
In
ma'am,
1 month, anything could have
yes,
happened.
ma'am, because it happened at the flap edge. It started from the flap edge and then gradually it proceeded towards the visual axis. So might have been some, like there might be an underlying inflammation which was
There
ongoing.
can be epithelial ingrowth also. It presents similarly.
Similarly,
But there was no sign of any epithelial ingrowth.
because usually if it's basement membrane, it should have happened just at the moment when the trauma took place. If the basement membrane
Yeah,
is loose.
intraoperatively, ma'am, it was totally uneventful. Like there was no epithelial abrasion or anything.
Okay, it's very good slides, good
Thank you.
presentation.
Thank you, ma'am.
Do we have?
So good morning, and I'm going to show you something similar on the lines of what Himani has shown, 3 cases. So this was a case where, the patient had -3 power and everything else was fine, and I did with a microkeratome, a BD microkeratome when I used, and just see when the keratome goes back, it's almost as if there's an entire flap that has been created, whereas in reality that is just the epithelium. The question was, what do I do now? Do I proceed or do I not? I decided to take the bit of risk, proceed with the LASIK, because either way, if it heals, it heals. If it doesn't, it doesn't. It's flap related, nothing to do with the LASIK. Look at the amount of epithelium that has come off, almost the entire thing. So what I did was, I cut off all the epithelium, like we know, no loose epithelium. I put on a BCL. Within a week, the patient had 6/9 vision. When I went for the other eye, almost after 3 weeks, I realized the same thing has happened there. Despite all precautions, changing the blade, and once again, look at the loose epithelium. It is almost coming off. So this is again a case of epithelial membrane dystrophy. Nothing else. It's happened in both the eyes, and it happened during surgery. Okay. Excuse me. Okay, the next case is another case where again I used the BD blade. This was a young patient from Mizoram, and fortunately for me, she wanted one eye at a time. So this was the first eye, and just look at that mark on the flap, and I should have been alerted when I was not able to lift up the flap the first time, and the mark persisted on the stroma. However, these were my early cases. I was not very alert. I thought it was okay. I did the surgery in the morning. In the afternoon, she came back with immense pain, and what I find is that for half the flap, there are only strands of epithelium. There is no 90 micron flap there. Half of it is 90 micron, the rest of it is just strands of epithelium. And I didn't know what to do, whether to take off the entire flap or to just cut off that epithelium. I decided to just remove the epithelium, leave half the flap on, put a BCL. It took almost 20 days to recover, but the patient ultimately had a 6/9 vision, though there was a thin haze there. And sorry, this is the first thing that came over. Interestingly, I did this patient again after 3 weeks, the other eye, and I had a similar finding. What I cannot find an explanation for is why is there the defect only in half the cornea? Why in that particular pattern? I've presented this in many places, and I've not got a satisfactory answer to this. Now the third case is something that is, the first two we had an explanation, it was a microkeratome. The third case is a femtolaser, which we know is very safe, but just look here, the laser part of it went very fine. I had nothing, no incidents, and here I'm trying to lift the flap, which is again, as you can see, it's like passing a knife through hot butter. In the first this thing, I always take three sweeps. The second sweep, it went right through the center of the flap, cut right through the center. That is when I realized that the other part of it had not even been dissected. It was sort of still adherent, and I didn't know what to do, but then I attempted. This is an edited thing. It took me almost 45 minutes first to make up my mind what to do and then to proceed with it. I somehow, sort of cut and lift, and a very ragged flap I got. I managed to pull it across, decided to proceed with the LASIK. My logic has always been that whether vision will come back, whether you do a LASIK or you don't do a LASIK, because it is flap dependent. So if the flap heals properly, if you do a LASIK, vision will come back. If it does not heal, then even if you don't do a LASIK, the vision will not come back properly. So at the end of it, I have pieces of flaps which I now have to place together like a jigsaw puzzle, trying to fit in all the corners. Took me a lot of time, but I was able to do it, except for this little bit that was rolled up like a cigar and which took me a lot of time. Ultimately, I was able to put it back into place, and the patient had good vision the very next day. So in this case, what had gone wrong? What had gone wrong is that the temperature in my OT had, the AC had stopped functioning in between. I had not realized that the temperature had gone up, which is why the laser had probably not fallen properly, which is why it's very important that we maintain the temperature and the humidity of the room while doing a femtoLASIK. Thank you so much.
Lovely. I myself don't have the answer for what went wrong.
That's
So,
why I presented it so many times, but I really don't.
but the
have an answer.
videos are very nice. Surprisingly, you did not lose your confidence and managed it. Many
That's
people
because you
would
are
just
seeing the case. You're not seeing me.
yes.
Believe me, my first instinct is to run from the OT, never
Exactly.
come
Anybody would want to do
And
that
then
the
I
way
keep-
they have torn out.
back. And I keep telling God, get me through this one, and never again in my life will I
And
do a
then they
LASIK
come back
surgery.
again.
Absolutely.
After 3 months, you had the daring to do it again.
We all have to move on.
Yeah, exactly. And it happened again.
Yeah, it happened again.
Wow.
I think the best part, intact IBD has gone into pieces. It's better to do a surface ablation later
The
on.
second case had a bit of a, I don't attempt surface ablation. That time we were not having the transepithelial thing. So I do not attempt a PRK if it is beyond 5. In fact, I'm
That's-
comfortable doing up till 3.
Or
Even
otherwise,
4, 5,
you
I
can
don't
choose the
like it.
ICL if you feel like.
Yeah.
I mean, it's much safer
Much
than doing,
safer, much safer.
doing cornea touching again.
Because only just think, because if in one eye it happened like that, so ideally you should have just
Expected it in
yeah,
the second
so that
eye,
you
but-
are also at peace. I feel you managed
Honestly
it. That is
speaking,
true.
At that time, we were
but,
not even doing the ICL that
Correct,
regularly. Now, yes, anywhere I see problem, go for the phakic IOL.
correct. Phakic IOLs are the best.
Much
I
safer,
think
much
right
safer.
now.
Second, if you get a problem in first eye, many of the patients have those problems second eye too.
Yes.
So we should be more cautious in doing
Cautious
second
when
eye of
doing
that patient.
I just have a question for you now. With all the problems that we face with laser and with having phakic IOL in the background, why are we still doing corneal procedures? Why are we not completely switching over to phakic IOL?
See, eventually I feel it is going to switch over to ICLs only, phakic IOLs, but then the cost is also a matter, and
think-
the technique. Doctors have to be trained. They are not. Everybody is not yet trained. Many are still trained in LASIK, and eventually things will change. Now the blades and also are going to stop getting manufactured, so you have to stop it. They are I think the companies are
Do you
only
think
stopping that
it is a
microkeratome.
safer procedure, because there is one argument which says that you might just go in for endophthalmitis?
No, not even endophthalmitis. You can go for glaucoma also. You can
Yes.
develop cataract also.
Yes.
So it's not totally complication free.
That is true.
Even if you do best of things, some patient may develop complications. In the cornea, most of the things are manageable.
Correct.
That's
Yeah, but most of the complications are that severe that hamper the vision, or that so that's why it make much safer also. So we got a lot of things in your surgical armamentarium. You can choose which one is fit for what. It's not the one procedure that's fit for all. Everybody is not for flap LASIK. Everybody is not fit for ICL. So naturally, or maybe a surface ablation too. So naturally, we have to choose a between. Thank
Okay.
you.
Thank you so
very
much.
much.
Thank you.
Never lift the flap. Most of the complication occurs once we lift a flap. Even if you're better to do it with a femto.
Okay.
Of course, we can do after the procedure also, but in a very demanding patient, the patient you don't think is going to be a 6x6 or going to get hematopia, but still you want to do it, then there's a thing I think can matter there.
Thank you, sir. Thank you so much.
Okay, so we move on. So the next speaker is Zain Khatib.
Thank you for the opportunity. So, I have basically two cases where I've shown, where we can do a transepithelial PTK in really bad LASIK complications. Okay, so this was a 35-year-old female. She had LASIK done elsewhere 6 months back. The right eye was okay, 6x6. The left eye was uncorrected, only 6x36. And this is her refraction, -2 with -2.5 cylinder. And on acceptance, she just had a -2.5 diopter sphere. She was only improving to 6/18 in the left eye. Contrast sensitivity also was much lower than normal. So if we look at the right eye post-op topography, this shows a good, topography consistent with a myopic LASIK with a good central flattening. But if we look at the left eye, you can see that this is not consistent with a myopic LASIK ablation. So you've got some kind of central steepening over there. And this is not ectasia because the pachymetry and all is normal. So what could have gone wrong here? If you look at the epithelial maps, which is something very important in today's time, the right eye epithelial map is consistent with a myopic LASIK, but the left eye you can see an abrupt thinning in the center. So when we look at the raw image of the OCT, on right eye we can actually trace the flap here. It's like a meniscus flap. And if we look at the left eye, we can see that in the center the flap is diffusing with the epithelium. So this most likely must have been a buttonhole, which may have happened, and the surgeon may have just gone ahead with doing the LASIK, what happens is that when there's a buttonhole, there's a central stromal island that is left behind, and the epithelial tries to compensate for it, but because of the bump, the epithelium is thin in the center. So in our case also, we saw abrupt thinning in the center and then adjacent thickening. So this was basically a buttonhole which now needed to be repaired. So whenever we have a buttonhole kind of situation where we've got a stromal bump, the only way we can treat this condition is if we remove the stromal bump. And the only way to remove the stromal bump is if we go all the way down, and this can be achieved by a transepithelial PTK. So if we do a PTK of the maximum epithelial thickness, we'll eliminate that bump. But then what also happens is that it is uniformly eliminated from all throughout. So you will get stromal ablation in the periphery. So we went ahead with a transepithelial PTK in this patient, explaining that you will require another procedure for refractive correction later. Right now we are not removing your number. So we did a 65 micron transepithelial PTK, and this is 2 months post PTK. As expected, we've got a residual sphere and cylinder, but the best corrected vision has improved to 6/12 now. And this is post-op 5 months. Now we can see the epithelium is, become fairly regularized, almost 50 microns everywhere. And now she's got a refraction of -3 with -1.25, with the best corrected vision improving to 6/9. And this is the topography post PTK. So we can see it's not an absolutely regular topography, but it's kind of better than what it was pre-PTK. Now, once we are satisfied that it is regular, now we will go ahead with doing another PTK with a refractive correction, and this will be a topo-guided refractive correction. So we did a 50 micron transepithelial PTK, and then we did a topo-guided treatment. And now post-operative 2 months, she's 6/9 unaided, and the topography looks fairly regular, and best corrected 6/6, and she's improving. Her contrast sensitivity has also now gone up. So these were 2 treatments done over a period of almost 7-8 months post LASIK, where she has improved now. This is another case, a bad case. A 33-year-old male operated for LASIK 9 months elsewhere. Pre-LASIK number was right eye -2.5, left eye -1. So left eye was done normally, but the patient says right eye surgery was aborted due to some flap-related complication. And right eye treatment was done with PRK 5 months back, that is 4 months after primary surgery. And the right eye had poor vision, no improvement. Again, right eye uncorrected vision is 6/36 partial. Autoref is showing a high cylinder, -5 cylinder in the right eye. And look at the right eye, there's a lot of scarring, and you can see a epithelial breakdown in the center. You can see a crab claw kind of appearance on topography. Epithelial map is very irregular. You can see a lot of hypertrophied areas of epithelium. And why the epithelium is hypertrophied, if we do a OCT raw image passing through the scarred area, we can see that because of that scarring, there is a flattening induced in that area, and the epithelium is trying to compensate and thickening. Similarly, we are seeing this. So our plan was, we again told the patient that you will require more than one procedure. We went ahead and did a transepithelial PTK of 100 microns so that we could go below the scar. And the idea was once we, ablate the scar, at least we are going to somehow negate that flattening which is caused because of the scar. So pre-op, this is post-op 3 months, and you can see post-op 1 year, the epithelium looks much better than what it was before. And when the epithelium is regular, we know that the surface below has become quite regular. And these are the pre and post 1 year follow-up raw OCT images. We can see that scarring has become quite less. And now we can see in the post-op 1 year a rim of scarring around, and that happens because we've removed stroma from that area. The refraction has not changed much, But subjectively, he's improving to 6/9 with a +1 -3 diopter cylinder at 165. So the topography now is quite regular, and we decided to do a phakic lens surgery to remove the refractive error. And now post the phakic lens, patient is 6/9 unaided. Contrast sensitivity is not great, but it is much better than before. So basically, I just wanted to show two cases where, cases which seem quite bad and non-salvageable, with transepithelial PTK, we can actually kind of, make the situation better. Thank you.
That's great. In the first case, you have removed whole the epithelium again, PTK.
Yes, sir.
We can have a selective PTK also. Or we can just do it manually in the central part. I think that also helps a lot. That gives you more regularity compared to if you did a PTK as such.
So the idea was that with that PTK to remove the stroma as well in the center. If we would do a
You did
manual...
some ablation also, stromal part.
Yeah, because we wanted to remove that stromal bump which is there. So that is why we use transepi. If we would have done manually, then the bump would have stayed.
Right.
And then we would not be able to do a treatment after that. It would again regrow the same way. So the idea was to regularize the stromal surface with the transepithelial PTK.
Right.
Sir, thank you.
Good morning, everyone. Thank you so much for the opportunity. Today, I'm going to present a rare case of iris depigmentation. So this was a case post a phakic lens implantation, and that is how we progressed with the case. So as we all are looking forward to that, eyes are the window to our soul. So the color of the eyes quite defines the person, and too much along with makes the insured to show the expressions around the world to everybody. So we had a 21-year male coming to us for spectacle independence who's been using regular glasses. His fundus showed myopic changes. The left eye was anisometropic amblyopia leading to best corrected 6/12, but the right eye corrected to 6/6 with glasses. Next up, when we did a pentacam to find out whether we can go ahead with a refractive surgery for this case, we found out that the corneal thickness was adequate enough and the bad map showed good results so that we could go ahead with the refractive surgery. But the consideration was that the right eye could go ahead for a laser vision correction and the left eye had to be planned for something else because the refractive correction was quite high. So we thought about different things to be done in both the eyes. That's how the ACD was calculated for left eye to be adequate. The gonio was fine with grade 3, grade 4 angle open, and the specular counts were normal. The plan of treatment that we defined was that we should go ahead with the right eye smile treatment and the left eye phakic lens. When further, the patient was operated for both the eyes in a gap of 1 day, and the post-op results show very encouraging to us that right eye was, with the smile, the patient corrected best to 6/6, and the left eye, despite of the phakic lens, the pre-op vision with the anisometropia was 6/12 part, but to our surprise, the patient read 6/9 post-op, so we were very happy with the results. The vault was very good, maintained with 770 microns. When the patient was called back after post-op 1 month, we saw the vault to be settled down at 706, but there was a high spike of IOP. When we saw a spike of IOP, it had to be managed with the anti-glaucoma drugs, and the patient's IOP controlled after around 20 days of treatment with the anti-glaucoma drugs of timolol. Following that, the patient was maintained with the IOP. That's how the anti-glaucoma drugs were withdrawn. When we called up the patient at 4 months post-op, he started complaining of left eye polyopia. The pressures were maintained without any AGM, and the best corrected vision was still maintained. The vault was good enough. When we did the gonioscopy, the angle showed moderate to heavily pigmentation of the TM. Following this, when we did a post-op day 1 pictures, I'm sorry, I won't have it on the slit lamp examination because there's no dictum to take a post-op normal picture for the patient. So the post-op day 1, iris and everything looked fine, the pattern and structure looked good. But when at post-op, month 4, when we looked at the patient, this was how the iris pigmentation had started changing for this patient. Following this, as a routine, because we had already done the OCT images for the vault, when we looked at the vault, the right eye, this is both the images of the left eye for the vault. So post-op day 1, we can see the iris looks very regular and fine in structure with no abnormality changes. But on the other hand, on post-op month 4, when we look at this patient, the iris has started showing the discoloration there. Following this, we do have the slit lamp images also to be compared, and the BCVA for both eyes was maintained with IOP well maintained and regular follow-ups to be seen with the patient. So, you know, this is a very erratic thing to be seen in a patient after the phakic IOL implantation. So we had to look back to the literature that why only one eye that we have undergone with the phakic lens, the patient is presented with the polyopia along with all of these changes that we see. So we look back and there's something called as the BADI that they have defined, that is bilateral acute depigmentation of the iris. But all of these reports that have been given in the past only show that either it can be related to some of the antibiotics, or it can be related to some of the anti-glaucoma drugs, or it can be related to a lens continuously rubbing over the iris to cause some depigmentation, which is not very significant in our patient in any way. So, and also sometimes the pigment dispersion also masquerades with the uveitis, but the patient's AC looks fine and there's no inflammation there. So the mystery remains for us whether this is because the patient was on AGM, but timolol is not known to cause any of these. The antibiotics, we haven't given anything other than the normal ones that we give, so that the antibiotics would have caused us, or the uveitic changes we don't see, and there's no history of viral. So here what I would like to conclude, that we need more such cases to be documented in such a way so that we can have more things to publish over it, that why a phakic lens can cause a depigmentation. But this has been just one case that we've encountered in such a long period of time. So I think the mystery still remains and we are still looking forward to this. Thank you.
Good. I think if there is a minor trauma on your ICL, that can lead to this condition.
I understand, sir, but retrospectively, one more thing we found out in that patient, that this patient had a history of glaucoma. So maybe some other consultant had started long back on a letonopros for this patient. But since the time we had been seeing this patient, the patient never came for an anti-glaucoma drug with us, like only timolol post-operatively for 20 days that we've given. So we are anticipating more to be related to an anti-glaucoma agent which has already caused the iris pigment changes prior, sometime back before the refractive surgery was being planned, and probably it has encountered in this way, because we do have anterions and everything also, so there's not even a little phakic lens touch on the iris or something that we can anticipate with having a continuous this thing. And actually another thing is, had it been that way, we could have seen pigment dispersion in the AC as well. We don't have a significant pigment to be released into the AC or on the phakic lens to justify that.
Very nice presentation.
Otherwise, there was no history of anti-glaucoma treatment.
No,
You
sir.
got it retrospectively.
Retrospectively, sir, when we asked, he said, I have a family history, so one of the consultant has started him on a prophylactic latanopros. But since the time he was there,
sorry to intervene. So latanopros must be being used in the other eye also, right?
Yes, probably, ma'am. Yes.
Yes.
But that patient underwent a phakic
In
this
only
smile
one
in
eye.
the other eye, so we
Smile in
anyway
the
did
other
not enter the AC. So
Correct.
probably that's why there was a no bilateral thing that we got with our patient.
Okay. Thank you.
Thank you so much. Thank you.